All right, so I'm going to be talking about alpha-1 antitrypsin tonight. Next slide. So I thought a couple of case presentations would be appropriate. However, for the sake of time, my husband is actually, you're going to hear from next, and he's used to waiting on me. However, I am going to try and make this a little more brief. So case scenarios I extracted from several sources. Typical scenarios that might trigger your clinical suspicion. So in the first, a 59-year-old never smoker female presented to the emergency department with assault. She had 5 years of elevated LFTs, dyspnea on exertion, and had multiple workups, including a chest x-ray, chest CT, and pulmonary function testing, but nothing was diagnostic. So this would be a typical presentation for a patient that you might consider to have alpha-1 antitrypsin. Her LFTs have been elevated. She had lifelong non-smoker. She had clubbing in this scenario, which is indicative of chronic hypoxia. And of course, she has dyspnea on exertion. Next slide, please. So for this next presentation, this is a baby boy who was in and out of the hospital. He was icteric upon his birth and had his splenomegaly and hepatomegaly as well. He had failure to thrive and a cholestatic pattern. So this is another individual that you would highly consider for alpha-1 antitrypsin. Next slide, please. All right, so what is alpha-1 antitrypsin? So it's a clinically under-recognized disorder. It is inherited. It's on autosomal co-dominant transmission, meaning that most of it's autosomal recessive. And when the gametes meet and meiosis occurs, then it replicates during mitotic division. It is a serine protein deficiency. So serine deficiencies are inborn metabolic errors that affect the synthesis of amino acids. So you can either have too much, too little, absent, or it can be a malfunction of such. These control or stabilize or unauthorized reactions to occur. So alpha-1 antitrypsin is the most abundant circulating serine protease inhibitor and acute phase reactant. It inhibits actions, and especially in the inflammatory response. So you have three lines of defense: your skin, the inflammatory response, and then your immune response. Whenever one is defected, then this creates fibrosis and changes within the cellular DNA and the metabolism. And alpha-1 antitrypsin, for instance, is produced by the liver, circulates to help prevent the breakdown of enzymes within various organs. And if there's a deficiency, then alpha-1 antitrypsin cannot control neutrophil elastase. So for instance, it can actually destroy the alveolar and the lung tissue, and then it can build up in the liver if there's an overproduction and it's a malfunction. And I think it's important to also note that it is on the long arm of chromosome 14. On the right side of the screen, I illustrated the clinical manifestations, primary being pulmonary, symptomology, hepatic, and then dermatologic. Next slide, please. So like I said, it's synthesized mainly by the liver. It's a protease inhibitor of serine proteolytic enzyme elastase, and it's a major blood component. And just for this presentation, I'm going to focus mainly on the liver effects. However, note that with the lung effects, it allows for neutrophil breakdown of elastin, which you can think the patient might have COPD. And if you test them at the later stages, they can have a slight reduction in their forced vital capacity and irreversible forced expiratory volume in 1 second. Next slide, please. All right, so this diagram, I thought it was important to note the normal pathophysiology for the acute phase reactant whenever you're comparing abnormalities. So in the normal acute phase reactant, what is happening here is that enzymes are released. So the inflammatory response of something entered your lung, whether that be a dust molecule, a microbe, what have you. So enzymes are released in low concentration, and this includes the complement cascade. So this is your bradykinin, which is, making vasodilation, and then the cytokines come in, the complement proteins, the interleukins, all of those come in to say, hey guys, something is happening here. We need to build the army up in order to combat this. So what alpha antitrypsin comes in, and that actually is released to limit the damage. So it's basically saying, let's concentrate all of our abilities in this one area. Let's not make this systemic and make everything destroyed. So with the lack of alpha-1 antitrypsin, you can have a very huge systemic inflammatory response. So what happens at that point is you have neutrophil granulocytosis, and elastase is then limited. So it kind of concentrates, the neutrophils granulate, and it concentrates in that area to limit damage otherwise. Then you have tissue degradation in that specific area and not everywhere else. And the damage is then once again limited, and the inflammatory response takes place with the help of T cells. At that point, the acute phase reactant ceases and your antagonistic threat is then cleared. Next slide, please. So what happens then whenever you have abnormal pathophysiology? So I think it's important to note here that you have genotypes of alpha-1 antitrypsin. Null is the most severe. If you have the homozygous null variant, it's most severe for the lungs, and the ZZ homozygous genome is the most severe for the liver. So if you have all those acute phase reactants saying, let's fight this, whatever it might be, then you have alpha-1 antitrypsin that's supposed to come along and actually downgrade the inflammatory response. But what happens here is that you have very little response, or it might be defective, or you might have none at all that actually comes into play here. And then what happens is that the neutrophil granulocytosis then occurs, and more of the lung tissue actually gets fibrotic and injured, and then COPD starts to set in. The same thing can happen with the liver. In fact, with too much accumulation in the liver, fibrosis then occurs. Next slide, please. All right, so what happens in the clinical manifestations of the pulmonary, hepatic, and dermatologic processes? So in the pulmonary, there is a loss generally of the alpha-1 antitrypsin. There's either a loss or a malfunction of the alpha-1 antitrypsin that's not allowing that elastic tissue to be protected. So you have a reduction of the elastic tissue, and then resultant forced vital capacity and irreversible FEV1 in 1 second, thinking that potentially they have COPD. Eventually, you could manifest as pulmonary failure. With the hepatic manifestations, the alpha-1 antitrypsin, you have an accumulation or an overaccumulation of this. There's increase accumulation in hepatocytes, and then obviously increase in the ALT, and it could result in liver failure. And liver failure, because of the changes in the metabolism with the DNA and the rough endoplasmic reticulum, you could then progress into hepatocellular carcinoma. Dermatologic manifestations, you have alpha-1 antitrypsin loss. And again, if you can imagine how much connective tissue you have and elasticity you have in your tissues, it decreases the integrity of your skin. Manifestations include skin disease and paniculitis and necrotizing paniculitis. Next slide, please. So who actually has this? So like I said previously, it's a widely underdiagnosed disease. We don't necessarily know the great data on who has the mild to moderate disease, but you do have the severe disease, which is mainly the ones that are diagnosed. Newborns have the genome of 10 to 15% of the time, and that's echoed in the adults as well. Next slide, please. So just before we actually go into what occurs in the liver, let's go into the lung again. It's the loss of function, destruction of elastase, and irreversible fibrotic changes in COPD. Next slide, please. So with the pathophysiology of the actual liver itself, you have toxic gain within the hepatocytes. So the hepatocytes, the intrahepatic accumulation of the alpha-1 antitrypsin molecules infiltrate within the hepatocytes. You have abnormal folding in the rough endoplasmic reticulum. So those, and again, it's either an addition of too many alpha-1 antitrypsin, or it's a molecular malfunction in which they just fold and bind incorrectly. That then leads to decreased degradation. Because of decreased degradation through the autophagy system, then you have a release of lysosomes. You have a bunch of lysosomes that try to capture these. And what happens is then they eventually have spillage that causes fibrosis, and resultant cell damage, and then fibrosis and potentially cirrhosis as well. Next slide, please. All right, this is kind of a very busy slide that I abstracted from the New England Journal of Medicine, and you can see how the rough endoplasmic reticulum is actually affected by the misfolding of the AAT, excuse me. This slide is just depicting what we were talking about before. This is more for the visual learners that like to look at pictures, how the liver and lung can actually affect itself and then manifest in the dermatologic system as well. Next slide, please. So whenever you're looking at this slide, like I said before, it's important to discover the specific genome. So the genome is important because different genomes have different severity of disease. And you can see on the very left-hand side of the screen, as you go upward towards the top of the screen, the alpha-1 antitrypsin levels increase. So for the liver, this is very severe and can cause fibrosis. The ZZ genome is heterogenetic, and it is the most severe form. If you have the null variant, it also has shown in studies to have differences and malfunctions perhaps in the rough endoplasmic reticulum, however, not enough to actually have any type of liver disease, and that's actually normal. What we're trying to see is the actual heterozygous types within the middle there, the SZ through the MS, and MM is the homozygous, but MS that actually account for these lost diagnoses. Next slide, please. So whenever you're looking at the liver, there are 150 known allelic variants. The heterozygous ones are the ones that are generally missed because you have to do further testing for those, which we'll talk about in the upcoming slides. But just note that the allelic variant ZZ is the most harmful for the liver, and the least harmful, which almost has a normal liver, is the null variant. But however, that's ongoing research is occurring. Next slide, please. All right, so for the lung, you'll see that it's kind of a little bit opposite. The null is then moved to the top. So the green arrow descending downward, the AAT levels are increasing there. So whenever you have the MM homozygous genome, it's actually normal, and you may not have any clinical manifestations of pulmonary disease. When you have the null homozygous type, you have the most severe disease because you have no protection from the alpha-1 antitrypsin, and insult continues to happen after antagonistic threats. Those ones in the middle, of course, are the ones that we need to focus on more in diagnosing as well. Next slide, please. So this is very rare, most often because it's just underdiagnosed. You have 80 to 100,000 individuals in the United States that have the severe form, and 3 million individuals worldwide. Again, it's highly underrecognized, and you have a 5 to 8 year delay from clinical manifestations. Next slide, please. So what are the risk factors? Basically, the only risk factor for both cohorts, adult, infant, and children, include genetic risk factors. So that's the most important thing to assess whenever you're looking over someone's history. Otherwise, history of asthma, recurrent URIs, symptoms that started in the 6th to 7th decades of life. However, most patients, it actually starts in the 4th to 5th. Obesity, alcohol intake, anything that can predispose them to a metabolic syndrome as well. And in the children and infant cohort, you want to look for idiopathic neonatal cholestasis that could predispose them to this through genetics. Next slide, please. All right, so for the sake of time, I'm just going to go over this briefly, but the history and physical for the adult and the children share some similarities as well. You'll have dyspnea, abdominal bloating, and ascites if there's a liver component, hepatomegaly, perhaps skin manifestations, although rare. You're looking again at the family history. If you're looking at children, you're looking at more foul smelling or pale white stools, poor weight gain, and failure to thrive. And again, children and infants will be usually icteric and have that cholestatic pattern. Next slide. So this picture I thought was a good manifestation of what you might see. We talked about the skin, we talked about the liver, the kidneys. If you have a patient with proliferative glomerulonephritis or IgA nephropathy, you may want to put this in the back of your mind as a trigger in order to think about, testing them for this if they have other clinical manifestations. Lungs, we talked about that as well. One thing we did not talk about is the vascular. If you have ANCA positive vasculitis or intracranial aneurysms or arterial fibromuscular dysplasia, these are kind of, triggers that you should think of in order to say, have a clinical suspicion if it's appropriate for your patient in order to test them. Next slide. And this is basically stating what that picture already said, but just look for these symptomologies within these two cohorts. Next slide. So what do we order initially for these patients? Adults and children are basically similar tests. The only test that you would order for an adult that a child or infant may be unable to complete would be the pulmonary function testing. So we'll start from the top, the CBC. What are you going to see in this? You might see secondary polycythemia, and this is just because they're creating more red blood cells to allow them to breathe and for their chronic hypoxia. You may also see thrombocytopenia due to the manifestation from their liver disease. Coags might be elevated again from their liver disease. LFTs, especially the ALT, you'll see as a primary abnormal lab, it'll be heightened. PFTs, you'll see that obstructive pattern that we talked about with the FVC and FEV1 ratio. The right upper quadrant ultrasound, you may see splenomegaly and heterogeneity of the liver. The CT scan, you'll see emphysematous changes on the CT scan as well. And ABG, you could see hypoxia and hypercapnia. So the children are exactly the same, except for you probably wouldn't perform the PFTs just because of their inability to perform them. Next slide. So this comes up from UpToDate. This is the diagnosis. So how exactly do you want to diagnose this? So if you have any clinical suspicion of this whatsoever, if the patient has COPD, if they have ANCA vasculitis, if they have bronchiectasis or elevated LFTs of any for an unknown reason, then you want to obtain an alpha-1 antitrypsin level and targeted genotype. So for the sake of variability and genome, different genetics, they use in this depiction of diagnosis under 20 micromoles per liter. Some use under 11, but under 20 seems to capture more of the population that is underdiagnosed. So if they do have an alpha-1 antitrypsin level of under 20, yes, then you review their genotype. If their genotype has the deficient variant, you sync your diagnosis. If they do not, then you perform sequencing with SERPINA1 and you're looking for rare or null variants. If you do, then yes, you have your diagnosis. If you don't, then you may just have a low AAT level without an actual genetic variant. Going back up to the top, again, if you have over 20 micromoles, then you still suspect the diagnosis, you might want to review the genotype. If it's a deficient variant, yes, then you might have a heterozygous type. If it's no, then you do not have the diagnosis. Next slide, please. All right, so this basically I depicted just for the liver, so the diagnostic pathway here. First of all, you want to look for clinical manifestations. If you have an elevated ALT and evidence of liver disease, you want to evaluate them for family history. Again, you want to check that AAT serum level. A lot of people use 11 micromoles, but you can use under 20 if you're thinking it's a heterozygous variant. And then you want to look more for that targeted genotyping. You want to look for the AAT gene mutation for those with severe disease, the ZZ homozygous or the null homozygous genome. Next slide. So after you diagnose someone with this, what exactly do you do from there? Usually a hepatologist and pulmonologist are already on board, but you want multifaceted consultants. So genetic counseling with a geneticist would be prudent if to test other family members, perhaps nutrition counseling, social work or psychosocial support therapies, PTOT and wound care, pulmonary rehab if there are pulmonary manifestations, and home oxygen referral if needed, and then transplant surgeon if needed as well. Next slide, please. So how do you treat this then? Unfortunately, there is no specific treatment. We will go through several treatments, but there is no specific pathway. It's supportive measures to mitigate the chronic liver disease, including metabolic syndrome. So mitigate the hyperlipidemia and obesity. Also, alcohol cessation is prudent. If this continues to progress, you have an 85% chance, 5-year survival rate with liver transplantation. Next slide, please. So liver transplant is only obviously for end-stage liver disease, and you have to ensure obviously that the transplant donor has a normal So they have no genetic variants or genetic abnormalities that would potentially worsen their alpha-1 antitrypsin. And if they in fact do have a normal alpha-1 antitrypsin, they can actually produce and secrete alpha-1 antitrypsin that can slow the progression of the lung and skin manifestations as well. Next slide. So treatments for the lung, and I'll just kind of briefly touch on these since we're mainly talking about liver, but if you have mild severe disease, obviously smoking cessation, nutrition, bronchodilators with short-acting beta agonists and muscarinic agents like ipratropium, corticosteroids, pulmonary rehab, oxygen if needed. It's important to treat early their upper and lower respiratory tract infections. In fact, there's been a large amount of research, including the anti-inflammatory effects of azithromycin. Again, getting their preventative vaccinations is prudent. If they have severe pulmonary disease, you can try alpha-1 proteinase inhibitor infusions, lung volume reduction surgery like a pneumoplasty, or double lung transplant. Experimental treatments do exist at this time, include aerosolized AAT, recombinant AAT with human plasma, endogenous AAT replacement, and also gene therapy. Next slide. So if you do have skin manifestations, it's really supportive nutritional wound care and surgical care if needed, topical dapsone and oral doxycycline for this as well. Next slide. So how do you monitor these people going forward? You monitor their symptomology, ask them how they are, check their ALT and their LFTs, obviously, perform PFTs to see if their lung functioning is worsening, check their coagulation panel and their platelet count to ensure that their liver disease is not worsening, chest x-rays, 6-minute ambulatory pulse ox, and a right upper quadrant ultrasound to ensure for hepatocellular changes, including hepatocellular carcinoma. Next slide. Complications and prognosis. So obviously for both cohorts, cirrhosis and hepatocellular carcinoma are potential complications. 40% of adults progress to cirrhosis and fulminant liver failure and sequential death. With children, 10 to 15% born with neonatal hepatitis, 5% actually progress to cirrhosis and death within the first year, unfortunately. And the onset of cirrhosis with subsequent death within the first decade of life. However, going back to what I originally stated, depending on the genotype and severity, there is an 85% 5-year survival rate with organ transplantation. Next slide. All right, so what do I want you to know from this? This is my highlight reel. So if you have neonatal or childhood diagnosis, you have to have a clinical suspicion with neonatal cholestasis. If it's acute, or if it's, adult onset diagnosis, look for these symptoms in the 4th and 5th decade of life and have a high clinical suspicion, especially in non-smokers or those with low risk factors. Under diagnosis of mild to moderate disease. So make sure that you're looking for this, have a clinical suspicion, early diagnosis, and check those AAT serum levels and genotyping if needed. And treatment is mainly supportive with multifaceted consultants and a severe organ transplantation. Next slide.